Okay, so can I proceed? We will be doing GIT. Where do you see breakbone fever? My question, where do you see breakbone fever? Yeah, then you correct. Okay, let's start with GIT. When we talk about conditions which affect the GIT, see, bleeding is not a disease. Yes, we do have heading as diseases, but do not get mistaken with that. Bleeding is not a disease of the GIT, it is a symptom of an underlying disease. Okay. So when you're doing an examination of the abdominal region, and if you do find bleeding, you have to take your inference based on where the bleeding is taking place. Now, all of us are familiar, we have different names, right? We have hematemesis, we have hematuria, we have melena. So, based on the site of the bleeding, you can determine what the disease is, right? So, when we talk of bleeding in the GI tract, we basically divide that into two types where we refer to it as the upper tract, that is the upper GIT, and your lower GIT bleeding. When we talk of upper, we are usually restricting ourselves to esophagus, stomach, and duodenum. Okay? Are we clear with it? Is it going fine? Okay. So, see, now think of, there is bleeding from the upper GI tract. What name will you give it? Hematemesis. That is whenever you're vomiting out red blood. Melena means what? Duodenum, right? So it can be bloody stools. So that will become melena. Now that you know the different sources and you know the types, what possibly could be the causes of it? Whenever there is a rupture of the varix, erosive gastritis, and peptic ulcers. Peptic ulcers, the most common symptom that you will see is bleeding. That's an MCQ. Did you guys get me? Understand this? In peptic ulcers, the most common symptom as well as the most common complication, symptom as well as complication is bleeding. A very, very favorite MCQ. Are we clear with it? Right. Next, lower GI bleeding. Actually, it can cause both. It can cause both. It actually depends upon the site. See, peptic ulcer is a broad term that is given for ulcers which are present in the duodenum, your stomach. Peptic ulcer is a broad name given for ulcers present in the stomach, duodenum, intestine, etc. So it's actually based on the site. Now, if you got a peptic ulcer in the upper half of the stomach, it can cause hematemesis. If it is close to the esophagus and the region between the end of the esophagus and the beginning of the stomach. Now, suppose if it is close to your intestines, if it is close to the duodenum, then it could be melena. So it can be both. Yes, correct, Rutaban. Peptic ulcers can be duodenal ulcers or they can be gastric ulcers. Correct. It could be anywhere. Yeah, so we have a diagram. Now see, my esophagus, let's make a continuity from the esophagus here. If your ulcer happens here, it could be hematemesis. If your ulcer happens here, it could be melena. Okay? If you go to the lower GI bleeding, it can happen from the small intestine and the colon. Mostly intestine related will be lower GI bleeding, okay, which will usually cause blood in stools. The name given for blood present in stools is hematochezia, MCQ. Alright? And what could be the causes for such a condition? Hemorrhoids. All of you know what is hemorrhoids? The common term given for it is piles. Piles के बारे में सुना है? It's basically varicose veins in the blood vessels present near your rectum. So what will happen? There will be an increase in the pressure. The patient is going to have a problem in defecation. So, with the increase in the pressure, in order to pass the stools, there will be a rupture of the blood vessels in and around that region, causing loss of blood from the stools. So that condition is hemorrhoids or piles. Anal fissures, neoplasms, diverticulum, inflammatory bowel disease. These are the causes for a bleeding from the lower GI tract. Now, when do we see change in the appearance of the stools? How much blood loss should take place so that it is visible to the naked eye in the stools? It's got to be more than 100 ml per day to be able to be visible as a change in the stools. Anything which is less than 100 ml will not really produce any change in the appearance of the stools. Is it fine? Now, let's go to the inspection part. When you have a patient who comes to you with a GIT disturbance, you will do examination, inspection, palpation, percussion, etc. When you're doing inspection, what is the thing you're looking at? I will tell you. Don't get frightened with it, I'll tell you. Hematuria is when you have red blood in stools. Melena is foul-smelling, tarry stools. When you have fresh blood passing out through stools, we call it hematochezia. It's fresh blood through the anus. They're actually black in color in melena. When we say tari, it basically refers to black color because this what happens is you have the blood oxidizing and becoming black in color. The hemoglobin oxidizes, becomes black in color. Okay. Back to the inspection. When you're examining the patient, you have to look for the region around the umbilicus. Okay, because the type of umbilicus will give you an idea about the condition. Okay. If you see over here, you can feel the umbilicus being slightly elevated, everted. So, your umbilicus, if normal, will be retracted and inverted. Think about it in a normal individual, the umbilicus will be inverted. While in any condition like an ascites, it would be everted. It would be outside. Then, You can also have, if you examine the skin, you could also see some striae. You know, you will see some linear marks. Can all of you see the linear marks here? Yes, you can also see such marks in pregnancy as well. Okay. You can also see pathologically in ascites. Purple striae will be seen in Cushing's syndrome. There is a change in the color. If you see pink or white linear marks, it is in pregnancy and ascites. If it's purple in color, it is in Cushing's. You can even have distended veins around the umbilicus. Can you see the distension of the veins around here? Yes, it can happen in case of a portal hypertension or a inferior venous obstruction. Inferior vena cava obstruction. Alright, that's about the inspection part. We go to palpation. All of you know the division of the abdomen area. Hypochondrium, epigastrium and all that. Let's just go through that. Can all of you see? The abdomen area is basically divided into 9 regions. We have the right and the left hypochondrium. The central uppermost will be epigastric, central umbilical, central below hypogastric. Then we have hypochondrium, lumbar and iliac, each on the right and the left side. All of you familiar with these 9 regions? Now, see over here. Where do you have the liver? So, if you have to palpate this organ, which possible site are you doing it in? You are doing it in the right hypochondriac region. Correct? Yeah. You will actually have your spleen somewhere here. So, that will be in the left hypochondriac region. Now, anything to do with the small intestine on this side will be in the lumbar region, right lumbar region. The rectum and the anus, either in the hypogastric or the left iliac region. Okay? Okay, let's go back to the previous slide. So, when you want to check for an enlarged liver, you will see in the right hypochondrium area, examination. Enlarged spleen will be in the left hypochondrium area. Now kidneys. Yes, let's go to the kidney that you guys were asking about. It will be bimanually palpable and dilutable. It's on both the sides. Actually, it's bimanually, no doubt, but I think the palpation will have to be a little more deeper, because if you're palpating superficially, you're possibly palpating just the intestines. Since you have your kidneys behind this, it's got to be a deep palpation. So, ideally should be the lumbar region, but a deeper palpation. I think it should be the lumbar only. Okay, then we have some signs for you. Both these signs could be asked as MCQ. We have Murphy's sign and we have, they may not be doing it from the back. It's possibly, I feel it is done from the side. I'm not sure though. I'm not a little 100% sure on that, but we can look for it, I guess. Same, bimanually, you're using both hands. Bimanually means one hand is kept on the top and one hand is kept below. Yes, I can give you guys a link that will show you the diagram on how to palpate the kidneys. That is what is meant by bimanual palpation, and the technique name is the ballotable type. Okay, let's go to the Murphy's sign. I have given you the link. You guys can go through it in the break. Now, I don't want all of you to go and see that. Kidney palpation is not important for us. Alright, let's get back to Murphy's sign. Murphy's sign is an example which has already been asked. Okay, you need to know where Murphy's sign is seen, what it is. It basically happens in cases of cholecystitis. Cholecystitis means what? It is an inflammation of the gallbladder. Okay, so in case of an acute cholecystitis, when there is a tenderness or rigidity, you will see the Murphy's sign. Alright, very important, it has been asked. Then we have the Rovsing's sign. Rovsing's sign is, actually it should be Roving's sign, not Rovsing's. It should be Roving's. Okay, the Roving sign is whenever you have tenderness in the right iliac fossa, whenever you apply pressure, you will feel the tenderness. So this is in an appendicitis. So in an acute appendicitis, if you are applying pressure in the right iliac fossa, you will find a tenderness over the descending colon. Right iliac fossa. Then we have something called as fluid thrill. Whenever there is a tense or a massive ascites, this is something that you guys must have done as an inspection in general medicine. Can you guys recollect doing the test for fluid thrill? When you tap, you will be able to hear that thing? Yes. Yeah, it used to be quite exciting. That used to be the only thing that used to take me to the medical college. Otherwise, I didn't find any reason going there and getting... anyways, yeah. Okay, yes. This we have done. Let's go to percussion. The percussion again, when you normally percuss the abdomen area, you will hear resonant sound. Now suppose there is ascites because of the fluid content, alright. Suppose if it's a moderate ascites, you will hear a shifting dullness. Shifting dullness, why? There is fluid over there, which when you tap is going to move, right? So that's why there's going to be a shift in the fluid, correct? So you will hear a dull sound because of the presence of a fluid. But you must note that an ascites, which is a tense ascites, okay? I mean, all of you can understand what a tense ascites is, right? See, if it's a moderate ascites, no, it's not. Tense ascites will be seen in case of a severe ascites. It's a severe condition. Now think of a situation when it is severe. See, when there is edema in the body also, it can stretch to how much of a connective tissue or interstitial tissue you have in the body. How can it stretch beyond that? Right? So there is only a certain limit to how much it can stretch. So the maximum stretch that happens, beyond which your body cannot. So that condition is going to be a severe ascites, and that will be a tense condition. Now in that case, you do a percussion. Where will the fluid move? There is no place at all for that fluid to shift over there. It's in that maximum stretched condition. So that's why you will not have a shifting dullness in a tense ascites. Then we have some term again here called as Puddle's sign. What I feel for general medicine is you got to be in the habit of writing. You have to take your point book, put heading general medicine, put all the signs together. And I actually told you guys to write down the signs for all the other subjects together as well. Even in oral surgery, we have so many signs. Coleman's sign, Gutman's sign. Alright? So put all these signs together so that when you revise them in one go and you don't have a confusion. Because when you read them in different pages, there's always a confusion on what did I read in the previous page. About 10 pages back, I read some sign what it is and it's forgotten. But if you have all the signs written together, you at least know that if you want to revise, they are all in one page for you to revise. And these things come very handy one day before the exam. Because you remember, you cannot sit with 10 books around you one day before the exam. It's humanly impossible to revise 10 books. If you ask Swati ma'am, she will tell, don't read anything one day before exam. Don't read anything before the exam. I would also say, don't read anything just before going to the exam hall. But you know, when you have things written like this, it comes really handy to you. Ek paper uthaya ya ek book uthaya and it's easy to revise. Correct? Okay. Now let's get back to the business. Puddle sign is when you have minimum ascitic fluid of about 120 ml, it can be elicited by auscultation and percussion technique. That is puddle sign. Now, Plummer-Vinson syndrome. I should be asking you questions. Triad. What is the triad of Plummer-Vinson syndrome? I will not be telling. I'll just sit back and wait for answers from you. You have to tell me what you see in Plummer-Vinson syndrome. The diagrams itself are enough to tell you what you see. Yes, it is because of iron deficiency anemia. Very good. What is the triad features? You see esophageal web, varices, correct, koilonychia. Koilonychia is nothing but spoon-shaped nails, which is what you see over here. You can see the koilonychia, the spoon-shaped nails. Yes, you can see the esophageal webs over here. And there will also be cheilitis. Yep. The one point that we already know, but yes, you commonly see it in women, more so in the post-menopausal women. All the other names, sideropenic dysphagia, Patterson-Kelly syndrome, Patterson-Brown-Kelly syndrome, all these other names are very important. Next we go to gastritis. Now gastritis means inflammation of the lining of the stomach. There can be a lot of causes for gastritis. We can have two types of gastritis. One is called as acute gastritis, and the other one is chronic gastritis. Acute causes can be because of excessive alcohol consumption or NSAIDs. NSAIDs and alcohol happen to be the most common causes for gastritis. This is an MCQ. NSAID related, in fact, happens to be the most common cause for peptic ulcers also. Are you guys able to follow what I'm saying? Most common cause for gastritis, alcohol, NSAID. Again, most common cause for peptic ulcer, NSAIDs. Fine? Chronic causes is related to bacteria. And when we talk of bacteria, most common is Helicobacter pylori. MCQ again. Are we clear? Clear with the acute causes and the chronic causes? Now let's go to the symptoms. Most common symptom that you will see is an upset in the abdomen or pain. Okay. Now before we could go into the different types of chronic gastritis, I will end the session here. It's time to end the session. You guys can log out and log in again, and we will see you at 8:10. And meanwhile, I want you to go through the different types of pulses, different types of fever, because before I could end my second session, I'm going to ask you questions. Clubbing, cyanosis, all that clinical methods, no? It's all there in your keynotes. Don't waste your time in that 10 minutes. Sit up and read that. Okay? I'll be logging out now.